Michelle and Marlena will get that out to you afterwards and with those details. Please make sure to mute your line, or I don't know, maybe Michelle is muted, folks, I'm not sure, not quite yet. But there's a mute in the bottom left of your screen that you can use to unmute yourself when you want to ask questions. You can submit questions along the way through the chat, and I'm hoping that maybe Michelle, Marlena can help me monitor that. And I think with that, we will share any kind of resources I mentioned after the webinar, as well as there'll be a PDF of the handout will be available later on as well. All right, great. It's great to see all these folks joining. All right. All right, so as I mentioned earlier, we're really going to dive into the topic of measurement-based care. I'm going to kind of present an overview, and I know some of this is new for some of you, and some of you have heard this or have already really been doing this work for quite a while in your health system. So I'm going to try to touch on something new for those who have been doing this work, but also kind of give you the overview as well for those who are new or who are trying to spread this work now, maybe to another clinic or within your initial partnership that you're working on. We're going to talk through registry options, so I'll talk about different ways to set up a registry for caseload tracking and kind of what some of those options are and the pros and cons, and what important features to consider as you're thinking about a registry for your health system. So on our last webinar, we really took a deep dive into this piece around team-based roles, and we talked a lot about the role of the behavioral health provider in primary care, the role of psychiatric providers, whether that be in a consultative role or in other roles, and the other care team members that are part of that team. Today, I'm going to talk further about these two additional principles around being population-based and data-driven. We're going to talk about how do you kind of define this group of patients and measure this group of patients over time, which we call a caseload, and making sure that no one falls through the cracks. We're going to talk about treat to target and how you use a registry for treat to target, and what do you do with this information and how do you use it to get patients better. So we're going to talk about these two additional principles. All right. I'm hoping some of you have had a chance to read this Kennedy Forum article. I think I showed it on one of our initial pre-work webinars. I think it's fantastic. For me, it was a really great overview, particularly for me coming from primary care when I'm thinking about, you know, what do we mean when we talk about measurement-based care for behavioral health? And their definition from this Kennedy Forum kind of white paper is it involves the systematic use of symptom rating scales to drive clinical decision making. They point out in this paper that it's really critical that you use these symptom rating scales such as the PHQ-9 or the GAD or the many others that are out there, that you use those tools related to that encounter. So they're not used as something that's not addressed, so given at the front desk, but no one ever addresses it. But to be effective, to do effective measurement-based care for behavioral health, you really need to have them be associated with that encounter, whether it be right before the encounter, during the encounter, right after the encounter, that people are using it and the patients know the value of their use, right? And that it's being addressed. One interesting thing that came out of this white paper too is that I was astounded by that only about 18% of psychiatrists and 11% of psychologists in the United States routinely administer symptom rating scales to monitor treatment response. So we have some work to do in this country, and this came out several years ago, and I think there's a lot of work that has been done. So we're really going to focus today on the use of kind of symptom rating scales, not just using it to screen a patient, but using it to really drive clinical decision making. And that's where the registry comes into place, because that's going to be where you're going to put this information to see if a patient's getting better or not, and to know if the patient's getting better or not. I haven't shared I don't think, this study that came out, but it's one that we like to point to early on when we're talking about collaborative care and knowing if patients are getting better or not. And it's really, for me, I was really wowed by this statistic. So this came out in, this was out of the Mayo Clinics out of Minnesota, and they looked at time to remission for depression with collaborative care versus usual care. So in a collaborative care program, so this is a program that uses treat to target principles, that uses site consultation, that embeds a behavioral health provider, patients in time to remission was 86 days compared to usual primary care, which was 614 days. So this work that all of you are embarking on, it's really about getting patients better, and it's using something like a PHQ-9 to help drive treatment to target and to help patients to know if patients are getting better or not, which we're going to talk a lot about today. When we say time to remission, just so people understand what these terms mean, time to remission means PHQ-9 less than 5. We also sometimes talk about response. That is a 50% improvement in the depression score. So when we think about, how you manage patients under collaborative care, we usually think about this around being around 6 months on average. Sometimes it can be more or less, depending. But something else that struck me out of the research is that 50 to 70% of patients need at least one change in treatment to improve. So if you think about your current practice in primary care, maybe you have recently prescribed an SSRI, or you refer that patient to behavioral health, or maybe you're seeing them for some kind of psychotherapy. But are those patients improving? And how do you know if they're improving? And the goal is really to get patients to improve with collaborative care. And so only 30–50% of patients respond fully to the first treatment. And so really proactively as a team monitoring something like PHQ, how often you're contacting that patient to see if that patient's not getting better over a certain period of time, what is something we can do differently? How can we maybe prescribe a different medication, or how can we maybe change our treatment approach or the way we're interacting with the patients, right? And so I think that's really important to consider. I'd be curious, for those of you who are currently practicing maybe on the call today, on average, how long do you think it takes for your patients currently with moderate to severe depression symptoms to improve in your practice? Could you just chat it in? Is it about 6 months? Is it a year? Is it 2 years? Do you know? Any thoughts out there? I'll be falling asleep already, hopefully. Thoughts? What do you think? Do you know? About 6 months? Good. Or 3 to 6 months? All right. So it sounds like you're pretty proactively monitoring these folks already in some of our practices. This is great. Anyone else out there? Any thoughts? All right. The answer is bigger than the question. Yeah, true. She's homeless. Other social determinants of health, other co-occurring disorders. I like it can help to show the patient the PHQ so they can see their scores. Ooh, I might call on the Bonnie Lake Clinic in a few minutes to tell me a little bit more about that, because I have a slide about that. Great. Thank you for your comments. All right, so I think for many of you, you know this already. So we're really talking about using behavioral health measures like a PHQ. And I use the PHQ a lot. We use that a lot initially here at the Ames Center when we talk about this work, because it has the most evidence as far as being a validated symptom rating scale that can be used for tracking treatment over time. We know there are many other screeners and other scales out there, and some do use them at different points in treatment, and we can talk about those as we work with you this year. But for the purposes of today's webinar, I'm going to be focusing pretty specifically on the PHQ, and it's the tool, it's the score that you're going to want to be monitoring too in your registry, which I'll talk about in a few minutes. All right, so thinking about them as vital signs, right? I like to have, when I think about the PHQ, I think you think often about like how we use blood pressure, right, in primary care. So imagine if you're, you're going into the doctor's office and you have hypertension, and the doctor says, hey, how are you feeling today? And doesn't take your blood pressure and says, okay, I think we're going to continue with your medication, and then you leave. That would seem really odd, wouldn't it? That they never took your blood pressure, you have hypertension, and they know that you're doing great. So we want you to have that same mindset when you're thinking about the PHQ, that it just becomes part of your clinical practice, and it's a tool to engage the patients. You already mentioned that one to someone. And it's also a tool for driving clinical decision making, right? All right. So when we're talking about measurement-based treatment to target, we're really looking at, having you use something like a PHQ to see how is that patient doing. It can help define your treatment goals. It can be used to help you determine, like, how often should you be contacting that patient? When should you reach out to that patient? Is it a patient that needs to be reviewed by the psychiatric consultant that you're working with, right? So really thinking about it as a tool to help facilitate clinical workflow. Do I need to change my treatment? Is something not working? Do I need to consult with a specialist about this patient? Is something need to be changed? All right, this is where I wanted to maybe, I don't know, Elizabeth or someone from the Bonnie Lake site said that it can be helpful to show the patient the PHQ. Oh, from Dr. Gardner. Dr. Gardner, could you say a little bit more about how you use it with your patients right now? I don't know if you can unmute. It's in the bottom left. I'd love to hear from you. Maybe?
Can you hear me now?
Yes, we can hear you.
Oh, great. Good. I'm sorry. I'm technically challenged. I know how to do a PHQ-9, but I'm not very good with a computer. So I would say that since I have started the classes here with the collaborative care, I've been a little bit more regular with doing my PHQs. And this morning I actually used it to try to, well, I would use the word convince with all of us, but to encourage a patient to give a different antidepressant a try, as her score was quite elevated and she has a lot of life issues going on. So I was able to use it to quantify and say, well, this is showing that your depression is fairly severe. And I usually use also talking to people about blood pressure. I said, if your blood pressure was elevated, I would be teaching you and showing you about medication for your blood pressure. But in this case, it is your, it's your depression scale, and we have medications that we can use as well. And this patient really was somebody that if I had had Dr. DeMonte down the aisle, I would have gone to grab him because it would have been a perfect patient. But anyway, I felt that it helped me to encourage her to try a new medication. And so I would say that I'm giving it a much better try than I had in the past.
That's a really great example. Thanks so much. Any other examples out there, how folks are using it currently? Thanks for sharing, Dr. Gardner. Anyone else? All right, there's some really great, I know I shared it with one of the teams I was coaching a week or two ago, so I think it was the CMAR team, that there's some free online modules, and we can make this resource available for behavioral health clinicians, although primary care providers, others could also view it. I got a lot out of them just viewing it, and I'm not a clinician, that really talks about, how to use the PHQ as a tool with patients to help with kind of self-management and to get them more aware about how they're feeling and their symptoms are. And so it's not just another piece of paper that they have to fill out that they have no idea why they're filling it out. But like I said before from that Kennedy Forum paper, it's really about associating kind of those symptom rating scales with that encounter and making it a useful tool so that patient can understand how they're feeling and maybe be able to better express themselves, right? There was a question here about the PHQ designed by Pfizer. How much does corporate finance play into it? I think that was maybe just a general question. I mean, there's a lot of research out there. I can show you some, if you need me to point you to some early studies around the PHQ, I can definitely do that. It is available. There's the PHQ screener website that is put out there by Pfizer that has it translated into many different languages. We can make that available as well. But it has the most evidence around its use. Maybe the person who made that comment, is there another tool that others are using for depression that they like using? There's many more that are out there, but. there's a different tool that's out there that you're using. Okay. All right. So I would be curious to know, right now, so we had one example of the use of the PHQ directly in an encounter with that patient. How do you tracking the score currently at that individual patient level? Is there anything you're doing right now with your EHR or on a spreadsheet, or just are you looking through past chart notes? What do you do currently? Could you give us some examples?
This is Dr. Garner again. We have our PHQ and the GAD are within Epic, and I actually am able to pull in the PHQ, the questions, and my patient's answers into my notes, so I can look back at the notes. Our EMR, I believe, will trend the past 3, so we can use that to look at. Anyway.
So you pull it into there, you trends your past 3, just your past 3.
Mm-hmm.
So you can't just see kind of the baseline and then, okay, interesting.
No, not yet. We're working on it.
All right. How about others out there? What do you do? Anyone else? Brett chimed in with another tool that he used called the Zung scale. Anyone else out there? Thanks, Dr. Garner, for sharing. Results in the chart notes I can review back on. Good. Before we move on, I would be curious from Comprehensive and Consejo, some of the other practices maybe from a behavioral health agency. Do you use the PHQ currently to track your patients? Maybe, maybe not, you don't know. For tracking. PHQ is being utilized at Comprehensive. Great. Can you see past scores? Assessment in the chart, so you can look back into the assessments. Great. Past scores are available. Good. All right, thanks, Elle. So that's my little overview around measurement-based care. You'll be hearing us talk more and more about this, and particularly our clinician trainers as they start to work with your behavioral health providers. It's a key piece in our in-person training that we're going to do with all of you in May. All right, I'm going to shift gears slightly, and I'm going to now talk a little bit more about registries. So I heard you share different ways that you currently can look back at on your PHQ scores. Maybe it's looking at past assessments, or maybe there's a tool in your EHR that shows you a few different scores and you can graph those scores. I think more and more in the EHR that I was using previously, we had finally built in an ability to be able to track. People had to enter in correctly that PHQ-9 information, but you could track over time and start to graph those PHQ scores. But there was a big push, there wasn't a big push at that time when I was practicing to have providers look at that tab or to look at how those PHQs were trending over time. And so that's a big piece, I think, as you're thinking of rolling out this program. I know many of you are working on your screening workflow, but also thinking about how those PHQs are used for clinical decision making, right? All right, so I'm going to talk a little bit now about what do you do with those scores under collaborative care and for measurement-based care, treat to target. And what do we mean when we say registry, particularly registry when we're talking about collaborative care, because there's many different types of registries that are out there. I like to start with this slide. So I grew up in primary care around the chronic care model, I'll say, and when I first learned and worked on a registry, it was specifically on using a registry under Ed Wagner's chronic care model. So to proactively identify patients, for instance, with diabetes or asthma or hypertension, to do that proactive time of care, to be able to say, hey, this patient hasn't come in 3 months for their diabetes visit, or their A1C is over 9, right? I think when you think of a registry, and back then it was in an Access database, and then we tried to build that functionality into our EHR, but we didn't get very far. So some of you probably have similar stories when you think about tracking chronic conditions over time. So when we say a registry, under the chronic care model, it was around tracking those patients maybe at the PCP panel level as well as at the clinic level to see overall as a clinic how are we performing as far as diabetes care goes, and who are those patients who needed a mailer or a phone call. The registry helped kind of facilitate this care planning and to help share information across providers, and to help also monitor performance. If you have any QI folks out there who liked registries, because you could see how you were doing in providing diabetes care, right? So that was under a chronic care model. When we're talking about a registry under collaborative care, we're talking about a real subset of your patients who are part of a behavioral health provider's caseload. That's a behavioral health provider that's embedded in primary care, right? Or maybe they're remote, but we'll talk in this case about embedded in primary care. And you're able to quickly see at an individual level, a caseload level, and sometimes you can see it broader than that, but really at the individual and caseload level, how those patients are doing. What is their score? When was your last contact? Have they been reviewed by that psychiatric provider recently to help drive treat to target and to know who is managing those patients? And so I think it's a real important distinction to make, especially because registry can be used in so many different ways. That when we're talking about a registry under collaborative care, it's that behavioral health provider's caseload of patients, which might be a few patients from one PCP, a few patients from another PCP that are in that clinic and who all make up that behavioral health provider's caseload. And you want to be able to quickly see, what is that PHQ score? Sometimes what is that GAD score? What that contact information was under collaborative care. All right. So for our caseload tracking tool, like for a registry, we're really looking at something that you can look at. You can look at the individual patient and say, okay, this was their last score, but you can also look quickly and say, out of these 50 patients, these 5 have a PHQ over 20, let's say, and these 5 haven't had a contact in the last month. So you can quickly narrow in and zoom in and say, I need to make a phone call to these patients, or I need to have these patients reviewed because their PHQ has not improved since their baseline. That's what we're talking about as a tracking tool when we're talking about a registry here for collaborative care. It helps you prioritize patients for treatment. It helps you prioritize patients for that caseload review. And as a behavioral health provider, it helps prioritize patients who you need to contact and do something with. Or maybe they're patients who have gotten better and you need to now transition them to what we call relapse prevention planning, and maybe they need less contacts and you're going back to that PCP because they've gotten better. Or maybe they need a different level of care too. All right. For those of you who have an interest in finance, and we get asked questions a lot right now around the collaborative care codes for billing, and we'll probably be touching on those further in a future webinar. But it is a requirement to have some sort of a registry. If you're going to go and bill the collaborative care codes under Medicare or Medicaid for reimbursement, you need to have a registry in place to track patients over time and know if patients are improving. The work we're doing right now under the Medicaid demonstration project and under your ACH, they cite under Project 2A the requirement of having a registry, either whether you're working under the collaborative care model or under the BRE collaboratives recommendations to have a tool to be able to engage and do treat to target and systematically follow up with patients. All right. Registry Options. So I'm going to talk through now kind of, I told you kind of what it is, what's its use, and I'll show you a lot of examples in a few minutes from the Ames Caseload Tracker, but I'm going to talk through kind of what are your options out there. So there are a couple different things to think about. One is the Ames Caseload Tracker, which I think we've already shared with many of your sites already, and we'll share the one page. I'll tell you more about it here too in a few minutes, but it's cloud-based and it's meant to be used with your EHR, so it's not to take the place of your EHR, it's just to give you a place to put the information that you cannot quickly put into an EHR to be able to get that caseload overview and that individual drill down view. So it's meant to be quickly able to be used for case reviews with the site consultant, the behavioral health provider. And so that's the Ames Caseload Tracker. The spreadsheet is an Excel spreadsheet, again, to capture this kind of essential information that we can't easily put into our EHR. Maybe you're working to build into your EHR, the next upgrade in your EHR you hope that it will have. But the patient tracking spreadsheet, I think several of you on this call actually currently use it. It's a free downloadable spreadsheet that can get you started on how do you do treat to target, how do you use a registry to monitor a caseload of patients. Few things to know though is it's a spreadsheet, so you have to figure out where you're going to securely store it, how you're going to be able to, if you're, let's say if you're partnering with another organization, how are you going to share the Excel spreadsheet? How are you going to make sure that the behavioral health provider and the site consultant can easily access it? So those are considerations with the spreadsheet. But the nice thing about it is that it's free, it's easy, you can download it today, you can even try it out to starting tomorrow. Both of these options come with guides. The Caseload Tracker has a lot of really great videos that come with it too to help get you started. And then everyone wants to know, well, can't we just build this darn functionality in our EHR, right? So for many of you, you're probably still trying to do that for other types of registry functionality, like I mentioned earlier, like for diabetes. And so for collaborative care, people want to know, can I build this functionality into our EHR? And we've worked with systems around the country, and we've seen many very expensive builds fail. We'll just say that. I think many EHRs are getting closer to being able to do it, but key things are, being able to accurately grab that initial baseline PHQ, being able to track that PHQ over time, being able to track it at that behavioral health provider level, being able to see was that site case review, did that happen recently? When was the last one? All of those pieces in a kind of an easy to read way. Particularly, I work with a lot of systems that are maybe working on a build in their EHR, but while we're with you this year, we want you to have a tool that you can use to start to learn the concepts of treat to target, measurement-based care, case review, et cetera. And so that's why using something like the spreadsheet or the Caseload Tracker is really the way to go, especially when we're working with you this year. Even if you're thinking, I'm going to build it into my EHR down the road, getting familiar with the use of a registry as a behavioral health provider takes some time, and it's one of the key things that we coach on here at the Ames Center. So what I would say is by May, when we do our in-person training for behavioral health providers in May, you're going to want to have your decision made as at your organization what you're going to use. Are you going to start out using just a Excel patient tracking spreadsheet to get the hang of it? Are you going to do the Ames Caseload Tracker? And we can talk more about the pros and cons of these options. What is it you're going to use? Because our clinician trainers, when we come together in May, we do a lot of exercises around how do you use a registry as a behavioral health provider for caseload review and for caseload tracking. And then as they coach during the following months, as they coach your teams, they're going to be asking questions around their use of that registry. So know that we want, that's why we're doing this webinar today, is because we want you to kind of be thinking about what you're going to do and what decision you're going to make as an organization, or if you're in a partnership, what tool you're going to be using. All right, I'm going to talk a little bit more about the Ames Caseload Tracker. It's the direction many organizations are going because it is cloud-based. It's HIPAA compliant, and it requires kind of minimal data entry. And the nice thing is that you can access it because it's cloud-based. So if you have a psychiatric consultant, so many of you are in these partnerships, and maybe the psych consultant or the behavioral health provider are in different organizations. They can log in from there, wherever they are, access it, quickly review the caseload. It has the ability to track that PHQ. It also has the GAD in it. You can see the baseline, the most recent scores. You can flag patients. You can see what's high, what patients have been on a caseload for maybe many weeks versus just 2 or 3 weeks. It gives you some population level metrics for your caseload around depression, remission, and response. And it also allows you to track minutes for the collaborative care billing codes if you're going to go that route approach and you want to track minutes every month to bill collaborative care codes. All right. People often ask us, who needs access to a registry? For what we're talking about for the purposes of today's call and for tracking a caseload of patients, it's really about that behavioral health provider and that psychiatric consultant. Sometimes someone else might also be responsible for entering a patient into the registry, but we often see, especially for something like the Caseload Tracker, where it's pretty minimal data entry, it's really looking at contact dates, PHQ scores, any psych consultant kind of notes that want to be mentioned, etc. So it's that behavioral health provider that's working alongside that PCP, directly working with the patient. And then it's that psychiatric consultant who's going to be preparing for a case review process every week. And also wanting to see kind of how patients are doing, and during that case review, pulling up the patients to see who's been flagged for consultation. So those are the 2 key pieces. Occasionally people want a PCP to also have access, but it's the behavioral health provider and the psych consultant will be feeding back information to the PCP on those individual patients. And they'll be the behavioral health provider is really managing. It's their caseload of patients that cut across different PCPs in the clinic. Other folks to have access would be someone like a supervisor, a manager, someone who can monitor caseload size and look and see, have all patients been consulted on recently, or have patients been engaged recently by phone, those kinds of things. So as far as people ask us how many accounts or who needs access, those are kind of key members of the team who need access to this caseload registry. So I'm going to show you I decided not to kind of do a demo and walk you through the Caseload Tracker today, but I'm going to show you some images of what it looks like so you can have a visual of what I'm talking about here. All right, so, and this is an example from the Ames Caseload Tracker. So here's the caseload report. So if I'm a behavioral health provider and I see, okay, here are my patients right now on my caseload, and what you can see at the caseload level is, again, you can see quickly who they are, when their first and last PHQ, the GAD scores are, the dates of assessments, follow-ups, psychiatric consultant, whether they're in relapse prevention. You'll learn a lot about that from our trainers, but that basically means that you've been working with that patient for maybe 6 months and kind of graduating from your work with them, but maybe you want to touch base with them still monthly or every other month just to see how they're doing for a little bit longer. Looking at how many sessions you've had with them, weeks since you initially started working with them. That can be helpful to know, hey, this patient is not improving. I've been working with them for 4 to 6 months. Maybe they need to be stepped into a different level of care, right? And then the minutes I mentioned before, people ask us, why minutes? And we added that because under the collaborative care codes for billing, and both under Medicare, Medicaid here in Washington, you need to be able to summarize your minutes each month if you're going to go ahead and bill those collaborative care codes. There is sorting functionality. It's pretty simple. You just click on the tops of these columns and you can sort very quickly. So if you have a caseload of 70 or 80 patients, you can identify very quickly, who has a PHQ-9 score that's very high, who has been flagged. You can identify by contact date, that kind of thing, really quickly. So there's a visit reminder screen. So this again will show you very quickly, when was the last time you contacted that patient. So we know a key to success with collaborative care to get patients better is having early engagement with that patient and contact early on that first month. Several contacts that first month is key to make sure that patients are successful in their work with you. So again, this is a quick reminder for your behavioral health provider on, okay, I haven't contacted this patient in a while, or this patient, it's been quite a while since our initial assessment. So that was sort of the caseload review for that behavioral health provider the caseload overview for that behavioral health provider. This is just, again, for that psychiatric consultant, we encourage them, they should have access as well to the caseload. And so they should be able to quickly, again, also identify patients. These flags over here are patients who have been manually flagged by the behavioral health provider who need a kind of a review. The PHQ-9 scores, again, are key for them to say, we should review this patient this week, or this patient's improving. Maybe they should be off the caseload or discharged back to the PCP. Contact information. So the PC column means psychiatric case review has happened. So initial new patients who've never had a case review, the psych consultant might say, I want to look into the EHR. I want to see what's going on with this patient. This might be a patient I want to bring up and discuss with the behavioral health provider. So sorting and all that can happen, but this just shows you kind of the review that happens. So this screen, what this screen shows you is this is then this would be an overview by each behavioral health provider. Here it says care manager because that's the term we use most commonly with collaborative care, but I'm using behavioral health provider today because I know everyone calls it a different position. But especially for managers or like a site consultant who's working with several clinics in the system, they want to quickly see how patients are doing with each behavioral health provider that they're working with. Maybe for managers, supervisors, they probably want to see too, like for their staff, how are they doing? What's their caseload size? How are patients improving? So looking at the no response, no remission columns for PHQ and the GAD, the average PHQ and the GAD scores, who have been flagged. There's 10 patients flagged with on a RATS list. Our director here at the Ames Center, I think we need to review them. So that's a good overview page for the site consultant. This shows you kind of clinic caseload statistics that you can quickly see, again, by clinicians. We do have built in to this, the Ames Caseload Tracker, the HEDIS depression remission response metrics. You can see that, and it rolls up by clinic here. It is that we've tried to mirror the HEDIS depression remission response metrics. You can see the definitions here. Just note that this is only on that caseload of patients that you have entered into the caseload tracker. It's not into your entire population for your clinic that's in your EHR, right? So minute tracker, when you go to enter the PHQ and your contact information, it also asks you about your minutes. So it can roll it up by patient because you need to summarize, in order to submit for reimbursement under Medicaid and Medicare, you need to know the total number of minutes, and if you're going to submit for a 60-minute encounter, a 30-minute encounter, etc. So that's what this screen shows you. And there are some of those reviews by patient at the individual level that give you the scores over time, kind of thing. All right, so I wanted to just kind of show you some of the different views in a registry like the Caseload Tracker, and so so you understand something of how you would use it clinically. I would be curious, I guess, for those of you on the call, I asked already about kind of how do you know if patients are getting better and what do you use? How about those of you, I think I know a couple of you on the call who currently use some tools to track your caseload of patients. Can you tell us about your experience? Anyone out there? Or do I have to call on people? Anyone? Dr. De Monte, could I call on you? I saw you on earlier. Or Porsche from CMAR, do you use anything right now? Anyone? Can people unmute themselves? It's in the bottom left. Share your experience. That's really the best way to learn. course, soon we'll be using the Ames. Yes, so I know that CMAR is working to set up the Ames Caseload Tracker. And I think they're using right now a spreadsheet to kind of do what they can. Dr. DeMonte, they've been having difficulty. Do you want to talk a little bit about your experience in using the patient tracking spreadsheet? Maybe, could you share with others?
Can you hear me now, Sarah?
Yes.
Okay. I didn't realize I had to unmute on my phone and the computer. So with the spreadsheet, we found that it was actually really helpful when starting out because it mimics a lot of the functions of the tracker. So as long as your caseload stays small, it works fairly well. The difficulty came as we really expanded our program and the larger caseload starts to make the Excel sheet not function particularly well. So even then you can come up with some creative solutions like starting a second spreadsheet or removing patients to a backup spreadsheet if they've left the program. So there's ways to kind of start out at low cost, but currently we're trying to find a registry that matches our scale a little more appropriately.
Great, thanks for sharing that. That's been my experience too. Often people will start out on the patient tracking spreadsheet to get a taste for what does this mean, measurement-based care, and what's the functionality all about. But then as they want to spread it, I'm working with one system right now, they're struggling with spreading it now to 8 different clinics, and how are they going to do that? And as you get more people trying to open up Excel spreadsheets, we found that you really need the Excel spreadsheet that we have to do this work. It's fancy, it has a lot of great functionality in it, but you need someone on your end who knows Excel well. Sometimes the behavioral health clinician's not the Excel expert, and so you need someone to be able to answer those questions in Excel. Like, how do you do this? How do you remove rows? How do you add more rows? We're at the maximum capacity of Excel. What do we do? Like Dr. DeMonte just shared. So, all right. Anyone else out there? Maybe everyone's just learning and starting. Let's see here. I guess I would like to know next, what registry options are folks considering? We've heard CMAR's, I know, going to move forward with the Caseload Tracker. The Franciscans are kind of trying to figure it out. Others out there, what are you thinking about using? And what questions do you have? What additional information do you need to help make your decision? So quiet. Anyone else? You unmute on the bottom left, or you might have to unmute your phone as well. Any questions for me about the different options I presented? EHR option. I don't know if our system can. Concerned about the cost of the Ames registry. Yeah, the EHR. I will say that yes, we work with many systems, and I have a couple of large systems I'm working with in the Midwest right now that are working on their Epic builds, but we've had them for now start on the patient tracking spreadsheet. They're looking at using like Synopsys and Epic and a couple other newer tools in their Epic system. But it takes time and resources. So for now, as they're learning about the functionality, they're using the patient tracking spreadsheet. The cost of the Ames Caseload Tracker. So we will put out there a one-pager of the details cost. It also has links to video demonstrations and other kind of key detail, the licensure information if you're interested in that. As far as cost goes, in case you're wondering number of users, so if you have 1 to 15 users, and remember key users are that behavioral health provider, that psych consultant, maybe like an administrative person. 1 to 15 users is $2,400 per year. 16 to 50 users is $4,000 per year. Working with NextGen, not great success is what I will say. Other questions out there? How about anyone who's working on a kind of a partnership? Maybe you have a behavioral health provider that's going to be part of that primary care team. What are folks thinking about as far as a registry? And maybe you haven't gotten far enough along. I'm just curious. All right, well, while you're thinking, I'm going to launch out the poll like we did before. I'm hoping it's here. Maybe it's not. Oh, it is. Great. Just tell us how we did today, and this was the information you needed to help with your registry decision. Go ahead and fill it out. It's 4 questions long. It'd be great to hear from you if this hit the mark or if you need additional information. You can also chat in to Marielena or send her an email if there's pieces of information that you're just not getting out of these webinars or you need additional technical assistance on. We have, there are a lot of resources on our website about registries, and so we have a whole, I put on here, and we'll put some of these links to on the portal to looking at different tracking options, some of the options I just reviewed for you. So there's links to the patient tracking spreadsheet, the Caseload Tracker. We also have a document as you are thinking about it, if you are thinking about an EHR build, or maybe 6 months from now thinking about an EHR build, that goes through the core kind of functionality you would need to consider for that EHR build. So keep that in mind, and those are all available on our website. I also mentioned some of the great tools around kind of training up providers around using the PHQ-9, and so I will make those tools available, I think, through the portal as well. All right, any other questions before we end today from folks? This is your great opportunity to ask questions about the different functionality, or if you're trying to decide around access or how it works. How does it work with also having to enter information in EHR? Any questions about that? Let's see the chat. CMAR, behavioral health provider in multi-care primary care setting. At this time, I've been utilizing a spreadsheet that I have created. Great. I think you must be the CMAR provider member who created a spreadsheet to track patients. Excited to learn more about the Ames spreadsheet. Great. There's a link on our, there's a link on our webpage. You can access that spreadsheet at any point to try it out. You know, I will mention, if you are part of these partnership teams and you are interested in licensing the Caseload Tracker, the licensure would reside with that kind of core team that has the patients. So in this instance, like multi-care would license the Caseload Tracker and then give access to that behavioral health provider that's embedded in that multi-care clinic. If that makes sense. I don't know if there's questions about that. We can also address those at an individual level. All right, any other questions out there, folks? Hopefully I've given you some food for thought to take back to your teams. I know Ann and I are working our way through each of your clinics. I have a couple additional site visits this week. I'm looking forward to learning more about kind of where you're at with your progress, and you can ask me questions then. If you haven't heard from Ann or I and you're still looking for a one-on-one with us, please don't hesitate to reach out or reach out to Michelle and Marielena. They can point you to us if you don't have our contact information. All right. Well, with that, I'll give you back a little bit of time in your day. Are there any other final questions? We have a lot of resources we will be following up with you on and putting on the portal. All right. I think our next webinar, we have one in March, and I'm thinking about talking a little bit more around screening workflow during that webinar. unless another topic comes up sooner than later. But maybe I'll see about having you all share your workflows around screening. So great. Well, it was great to see so many of you on the call today, and thank you. And feel free to reach out with additional questions. All right. Bye, everyone.
Thank you.
Thank you.
Yep.